Good morning, everybody. I'm Dr. Lucas Hopkins. I'm one of the internal medicine chief residents over at Wellstar Kennestone Regional Medical Center, which is in Marietta, Georgia, just slightly northwest of Atlanta, Georgia. Today, it's my goal to just shed a little bit of light on a remarkable case that I believe highlights the link between Pembrolizumab, which for your and my sake, I will call the brand name of Keytruda, and a rather unexpected complication of diabetic ketoacidosis or DKA. Keytruda, a little background on this humanized monoclonal antibody used in cancer treatment, has gained some recognition for its efficacy in enhancing anti-tumor response. However, like any medication, it does comes with its own kind of share of side effects. Most notably, acute hepatitis has been linked to it, reactive pneumonitis, your classic kind of chemotherapy, GI symptoms, diarrhea, nausea, vomiting, and skin reactions. Today, we will explore a little bit of a unique case involving a non-diabetic patient that we saw on the hospitalist side and eventually developed a DKA quite shortly after initiating Keytruda. So allow me to introduce you to our patient. This is an 86-year-old female. She was diagnosed with non-small cell lung cancer 1 month prior to being seen by us. She began her treatment with Keytruda approximately 3 weeks before her admission to Kennestone Hospital. She then developed altered mental status at home, prompting family members to proceed to go to the emergency department. The initial ED documentation did show she was found to be encephalopathic, hypotensive, tachycardic. She had accompanied blood sugar initially of 994. Further investigation in the ED did show that she had an A1C of 6.5. Notably with that, she did have a baseline A1C before Keytruda initiation of 5.4. A creatinine of 1.9 was also noted, lactic acid 3.9, bicarb of 9 with a lovely beta hydroxybutyrate greater than 5 and a GAP of 36 to accompany that. Further UA showed 2+ ketones. We did a little picture here of a CT abdomen showing that there was no pancreatic architecture abnormalities outside of that either, just to kind of rule out secondary causes as well. But essentially due to her condition, severity of her condition, she was requiring vasopressors in the ED. We decided to call the ICU team down to get her admitted to the ICU. Started an insulin drip as well, as transferred to the ICU for a couple days. Subsequently, she was transferred back to the floor for management by hospital medicine for further transition off of the insulin drip and workup for secondary causes. We did do some extensive investigation into secondary causes of DKA. Further showed that patient, sorry, I got a little lost in my speech here. I got a little bit, ruled out secondary causes, so no signs of infections, cardiac ischemia, pancreatitis, substance use or iatrogenic agents, specifically hypoglycemics in her case. So this really just left us with the only plausible cause of DKA in our patient to be Keytruda. Although it is widely recognized that previously mentioned side effects, the occurrence of DKA is relatively rare, with an observed incidence of only 0.7% within the class of immunotherapies to which Keytruda does belong to. Upon discharge, she was giving a Lantus of 12 units daily and a mealtime prandial insulin of 6 units. So to kind of switch gears a little bit, I did want to discuss a little bit more about this phenomena itself. So to the best of our knowledge, there were about less than 20 case reports in total of this association, and case series included with that, of development of DKA in the setting of a patient that had no previous diabetes. It is widely recognized that immune-related endocrinopathies, including thyroid dysfunction, hypophysitis, are more commonly reported. However, for the immune checkpoint inhibitors, induced diabetes has been recognized as a rare adverse event with the PD-1 or PD-L1 inhibitors, though the pathophysiological process does remain poorly understood. There is one prior case series that we found suggesting that there was a median time of Keytruda initiation to DKA was about 15.8 weeks with a range of 1 to 16 weeks. Most patients, approximately 85%, already did have pre-existing diabetes mellitus, while others developed this after initiation of Keytruda. The observed incidence of DKA with this class of immunotherapy has been previously found to be 0.7%, with no preponderance in cancer types. DKA presentation was severely more severe in the cases who also had prior diabetes as well. So kind of bringing this all back to our patient, her characteristics were similar to a few of the previous case reports that were documented. However, she did differ from the prototypical presentation with a few key factors. Our patient was much older, being 86 years old, versus the mean stereotypical of 61 years in prior reports in case series. The previous reported mean duration of the onset of DKA from the initiation was also 15.8 weeks versus our patient that only had a 3-week initiation period. This also coincides with her lower A1C of 6.5, rising from 5.5 the month prior, suggesting that this was indeed an acute phenomena that is lower in comparison to the previous case reports as well. Several factors have also been thought to increase a patient's risk of developing this disease, such as personal or family history of autoimmune diseases, most notably thyroiditis, or prior treatments with immunotherapies, which both of these lacked in our patient presenting today. So in conclusion, our case does highlight the importance of considering Keytruda as a potential cause of DKA, even in a non-diabetic patient who may have initiated Keytruda. With the exclusion of other possible causes, Keytruda does stand out as the only reasonable explanation for DKA in our patient. This unique case, I believe, does serve as a reminder for healthcare providers and certainly for myself managing this patient to remain very vigilant and consider the kind of broader range of side effects associated with these medications, even with documented adverse effects in clinical trials. So as we continue to advance the field of, I believe, immunotherapy, I do believe it becomes increasingly more vital to uncover and understand the various potential complications that may arise. And by doing so, we can provide optimal care for our patients, ultimately mitigating any unforeseen risk that may arise with treatment. So with that being said, thank you all for your time and attention. I do hope that this case does spark your interest in exploring this kind of intricate relationship between Keytruda and new onset diabetes or DKA.